Good afternoon, everyone. Learning to work the phones and the computers in the land of Zoom, this is the way it goes, right? We are so honored to have you this afternoon for our fourth We're in 2020 webinar. It is October 13th. Somehow we're entering the last quarter of this unbelievable year, and we have a really full, wonderful agenda for you today. We'll be hearing from friends at Atrium Health in North Carolina, who will be sharing information about their HPV quality improvement initiative and how they've actually managed to somehow raise HPV vaccination rates during the pandemic. And then we'll be hearing from Dr. Debbie Saslow at the American Cancer Society on some exciting new guidelines and research developments. I'm Jennifer Konga. I'm one of the two directors of the National HPV Vaccination Roundtable, and I'm going to begin with giving some context and background since we last met and spoke earlier this year. So first off, I'd love to welcome, we have about 6 new organizations that signed on to We're In, highlighted in the darker orange, and up to 46 organizations overall that have made a formal commitment to raise HPV vaccination rates. So thank you for your commitment. We also want to set the stage before you hear Dr. Noose's presentation with some background context on news that we have around HPV vaccination. So we're going to start first. Many of you are already aware that NIS team data from 2019 came out in late August. And the great news is that rates went up from 51% in 2018 to 54% in 2019. Wonderful news for up-to-date rates, so 2 or 3 shots by age 15. But as you can see, we still have some work to do to catch up with those other vaccines. We also have data from CDC showing how teens are faring by insurance coverage. And so we know that teens who have Medicaid coverage have the highest up-to-date rates for HPV vaccination at 59%, followed by 53% of teens with private insurance, almost 50% of teens with other insurance, and that could be from Indian Health Service, CHIP, or military insurance, and then uninsured children, smaller in number, but very low percentage, about 1 in 3 who are actually fully vaccinated. So I want you to keep in mind this high 59% for Medicaid coverage as we go along. We also wanted to provide you some good news, but also be alert news around HPV vaccine ordering this year during the pandemic. As you've heard from media, childhood and adolescent immunization has taken a hit due to COVID-19. And what you see here are HPV vaccine ordering rates from January through October. So there's some bad news and some really encouraging news here. Just got this in from our colleagues at CDC this morning. So this is fresh off the wire. What you see in gray here are rates of ordering for vaccine for children HPV in 2019, and the green are 2020. And that dotted number 2 line is when the U.S. national emergency was declared. So you can see that in late spring to early summer, HPV vaccination ordering took a nosedive. And that gap between the green and the gray was significant. But what we're beginning to see as you look into the early fall months is that that gap has started to close with vaccine ordering to the most current data, which looks like the 5th of October. It is the first month of this year where we're actually ahead of what was ordered last October. So keep this in mind. There's a lot of catch-up that has to happen. The last piece of context is information that came out from the Centers for Medicaid and Medicare at the end of September. They issued 2 press releases and supporting data, calling our attention to the drastic decline in children Medicaid visits. Over 40 million children are covered by Medicaid and CHIP in this country. and that includes 3/4 of children living in poverty. So this solid blue line are visits from March through May of this year. And you can see that these childhood screening services have dropped 44% over previous years when we compare to May of 2019. 3.2 million kids, fewer kids got screening services. Now, granted, this is all children, but this is a significant decrease that we need to be aware of. A week later, CMS released 12 months of data on the trends in enrollment for Medicaid and CHIP. So if you look at the red line on this data chart, this is the combination of child Medicaid and CHIP enrollment. And you can see from March through June, that trend line going up. And that increased by over 1.4 million children who've been added to the rolls. So we know, in summary, that kids on Medicaid are most likely to get vaccinated fully when they have Medicaid insurance. The enrollment is going up, but that over the course of 2020, those visits have gone significantly down. And so CMS has called upon us to do two key things as stakeholders to help address this crisis. Number one, we need to work to return to those prior year primary and preventive care visit levels and catch up. And we have to catch up on immunizations, medical visits, behavioral health, and dental. So as we invited you to this call today, we shared a new white paper that was a summary of the We're in July call with promising practices during COVID. So if you haven't checked out this document, please visit our website and do so. It is input from dozens of organizations that shared what they were doing to increase vaccination for adolescents during COVID, and just a fantastic resource. But today, even better, you're going to be hearing from a colleague who's been leading this work on the ground in North Carolina. So it's my privilege to introduce to you Dr. Lynn News, who's the Specialty Medical Director of General Pediatrics for Atrium Health, Levine Children's, and a practicing pediatrician with over 20 years of experience. Dr. News graduated from West Virginia University School of Medicine and completed her residency in internal medicine and pediatrics. So with that, Dr. News, I'll turn it over to you.
Thank you so much, Jennifer, and thank you for the invitation to us to be able to share our story. I'd also like to introduce my co-presenter today, who is Stephanie Rains. She is a nurse with Atrium Health in our quality department and is one of our performance improvement coordinators for general pediatrics. So I thought I'd kind of start just by sharing who are we. Atrium Health rebranded about 2 years ago now. We were formerly known as Carolina's Healthcare System. We are headquartered in Charlotte, North Carolina, and our entire organization is a network of over 40 hospitals and 900 care locations throughout both North and South Carolina, as well as Georgia. You may have heard about us within the past week, as we recently joined with Wake Forest Baptist Health and Wake Forest University School of Medicine. And that is a hot off the presses partnership that we're really excited about. Our medical group, as it currently exists, has over 3,000 physicians and APPs. Now, Atrium Health Levine Children's is actually a service line dedicated to children's health within the medical group. It's composed of Levine Children's Hospital, Jeff Gordon Children's Center, over 32 general pediatric clinics, and 3 large specialty clinics. And my area of responsibility is the 32 general pediatric clinics. And our service line is ranked by US News and World Report in 8 different specialties. I also wanted to share a little bit about our quality journey, because our experience over 2020 actually is not isolated just to the last 10 months. It really is a long-standing journey. Atrium Health has a quality program that spans our enterprise, including inpatient and outpatient, and has been in place for well over a decade. But about 5 years ago, we actually were able to separate pediatrics out into its own quality work group. And that was really formed because we found that the metrics available to our adult colleagues didn't really have applicability within our world. And so we wanted to really start driving quality of healthcare within those children under 18. So our first question that we ever asked ourselves was, what is the right thing to do for our patients? And that is the question we ask ourselves every year when we look to make decisions about what work we're going to do for the ensuing year. At the time when we started this journey for HPV vaccine, our rate of vaccination was only 12% complete, and that was only in females by age 13, because males were not included in the HEDIS metric at that time. And so since then, we've expanded the metric to include males and to look at completion rates within different age groups as well. And most of you are probably familiar with the HEDIS metric for adolescent vaccines that also includes Tdap and meningococcal vaccine. But we elected to pull HPV out because that's really where we need it to work. Our other adolescent vaccine rates are greater than 90% and have remained so over the last 5 years. To fast forward, and about this time last year, we were able to partner with the American Cancer Society on a quality improvement project that offered maintenance of certification credit all around improving our rates of HPV vaccine completion and initiation. And really, this partnership allows us to focus on provider education and training and the announcement approach. And as a result of this training, we really have been able to achieve our greatest performance to date. Why HPV vaccine? It's really as simple as we want to prevent cancer and to take every opportunity we can to do that. All right, Stephanie, I'm going to turn this part over to you.
Thank you so much, Dr. News. As Dr. News previously mentioned, I'm a performance improvement coordinator with Atrium Health. Obviously having some technical difficulties today, not sharing my camera for that reason, but I am able to share audio. So thank you all for having us. Why did we choose to do this project with the American Cancer Society? You know, we continue to struggle in pockets of our division and within certain practices, but there was no real discernible pattern. It wasn't the larger clinics struggling or smaller clinics, or, you know, was it mostly high Medicaid practitioners or commercial payers? It was really fairly random. And we continue to see a little bit of that as we go through this project. We also chose to, you know, partner across service lines, which was a great thing. We wanted to include our family medicine practices because they see about 15% of the children within Atrium Health. We were also able to partner with a gynecologic oncologist as an expert presenter within the first webinar staff meeting with the MOC project. And that was great for our pediatric team to be able to hear, you know, what he has to see when we don't try to prevent this with the vaccine, or for patients of his who are not eligible for the vaccine due to age parameters. We are offering MOC, or the project is offering MOC We have about 32 general peds practices and 5 family medicine practices involved in the project. And we do have one more staff meeting or webinar to go through before the project is complete, and then another data pool. So we're hoping that we continue to see increases in our rates as we go throughout the rest of the year and the beginning of 2021. Next slide. So our aim statement for the project was that Atrium Health would aim to increase HPV vaccination initiation rates by 10% and completion rates by 15% among 11 to 13-year-old adolescents by January 31 of 2021 at all clinic sites participating in the MOC-QI project, which I mentioned before is about 32 pediatric sites and 5 family medicine. The ultimate goal of this project is to meet or exceed the 80% completion rate by 2026 in accordance with the ACS Mission HPV Cancer-Free goal. Next slide. So this is a graphic or a run chart that from our pediatric service line within Atrium Health. And you can see here, this is measuring ages 11 through 17 for completion only. But we pretty much mimicked what Jennifer was speaking to earlier with having a pretty steady decline after the pandemic started in March until about June. And then once we were able to start seeing well child visits back in the clinic and get patients back in June, we have continued to see an uptick month over month. And actually, as of today, we're at 53.3% instead of the 52.7 that we pulled last week. This slide, is an overall graphic that we share each month with our teams and our practices, and we'll even take this down to the practice and provider level as well.
So when we were asked to present this and kind of give our impression of why we thought we were able to be successful during especially challenging times this year, and really felt that the keys to success kind of fell into what I'll term the 3 E's. So the first is establishing the why, educate, and execute. Next slide. Establishing the why. This builds the entire foundation for how successful I think an organization can be in driving rates. So I can't really underemphasize or overemphasize, I should say, the role that leadership plays in establishing and really articulating the vision, why HPV vaccine is so important, why we need to invest our time and our energy in it. And within our division, there's myself as specialty medical director. We have 4 assistant specialty directors who then have responsibility for regions that our clinics are in. And each clinic also has a site-based medical director. So we have established communication pathways and ways that we try and keep everybody onboarded into any initiative that we undertake and keep moving in the right direction, which is all well and good. But if the front line isn't involved as well, then really we risk everything just stopping at the level of leadership and not being able to execute. So one of the things that we did in the last couple of years is expand our quality committee to include frontline physicians and APPs who represent that non-leader viewpoint. And it helps them understand why we have a quality program, why we do things the way that we do. And it helps them to also spread that message to their colleagues from a little bit different viewpoint than what a leader may bring to it. And finally, change isn't easy. We all know that. We're kind of living it moment to moment and day to day right now. And so it is important to acknowledge that this is hard work. It's not just change for us as providers and teammates, um, but it's a change for a lot of our parents as well, because we all know parents come into these visits often with preconceptions around HPV vaccine due to a lot of misinformation. Educate, this really falls into 3 levels of education. So, um, educating providers, I think involving our expert colleague through gyn oncology was really helpful for us as pediatricians to see how this hard work pays off in the future and what an impact that we can have, not just in the here and now, but really on adult health as well. I often use the phrase, as pediatricians, we build the future, and this is one really great example of how we can impact the future of our families and our patients. Um, Educating staff, the way that we do the flow of visits is probably the same as every other clinic or healthcare organization. And our medical assistants are the ones who see our patients as they room them and do their vitals. And they announce what vaccines are due at that visit, kind of helping to set the agenda for the well visit. So it's important for them to really understand the importance of what they're saying and why they're saying it, um, so that parents can hear the exact same message from every person they encounter during the visit. And finally, educating parents and patients. Um, for me, I have found the most helpful workflow for this is to actually kind of start teeing up the expectation at the 9 to 10-year-old visit. We do routinely immunize for HPV at the 11-year-old visit, along with Tdap and Menveo is what we use. And so oftentimes, just in interacting with my families, if the 11-year-old visit is the first time they're hearing about HPV vaccine, they've got all this misinformation in their heads, stories they've heard from other people, things they've read online. And so they really want the time to kind of digest what I have to say and to think about it. Whereas if I take the time a year or two before and start having the conversations, I'm much more likely to be able to have them vaccinate on time at 11 years old. The other thing that really came directly from our partnership with the American Cancer Society over this past year is making sure that I articulate the focus on cancer prevention. That this is above and beyond anything else. This is all about preventing cancer in this child's future. And so having the ability to steer the conversation away from, well, this is sexually transmitted, my child's not sexually active, aren't they too young? And explaining that in order to prevent cancer and to give the greatest protection, we give it at this young age when the child has the greatest immune response to the vaccine. That has been exceptionally effective for my parents, and has really made a difference in the conversations that I'm able to have with them. The other important thing is, emphasizing that we need to acknowledge the parents' concern, restate it to them so that they understand they are heard, and then give them the appropriate facts from there. And finally, dispelling the myths as we educate parents and patients. I have to acknowledge the role of social media. because we often see it as a negative, and how it spreads misinformation around HPV vaccine is one example. But it also can be a powerful tool for education, and that's one of the things that we incorporated over the years as we've tried to improve our rates, is using social media as a platform to spread this education. Now, I did specifically call out patients in this line, and I forgot to mention, but another tool is, surprisingly, I've had many patients, as soon as I start talking about preventing cancer, pipe up and say, well, I don't want to get cancer. And for a parent to hear that from their child also has a really powerful message behind it.
So the last E would be execute. And this is where we really work with our practices and teams to measure. What you measure, you tend to improve upon. So we set very clear goals and review these with our practices year over year to make sure they understand how we're measuring, what we're looking at, how you achieve the measure. And then we actually have performance reports that we share with them. We're very transparent. I think that helps create, a nice competitive sometimes environment, but also, very apparent, to know what your colleagues are doing and what each practice is doing. Maybe they have a best practice that we can learn from, so forth and so on. And so we do measure at the division level, at the clinic level, and then down to each individual provider as well. They can get that data as often as, every other day potentially, but we generally share the feedback monthly with practices, and more often if we're doing certain targeted practices, performance improvement practices with clinic. So if they are doing a big recall campaign per se, we may pull the data more often. And it's very, very important that we do a data review with each of the ACS MOC webinar or staff meetings that we have. That way we can see improvement from the initial to the second to the last webinar. The other thing that we work on is trying to remove barriers. As Dr. Neuse mentioned, social media sometimes does not help us. We do try to combat that and educate the community by doing our own marketing on social media to help explain the need for the HPV vaccine. But there are barriers and websites and blogs out there that patients come in, quoting and stating that, they're concerned. So we try to work and make sure our entire team at the clinic knows, what is our mission and what are we trying to do? And like Dr. Neuse mentioned, it's to prevent cancer.
So I'll just jump in a little bit. Stephanie's role and her partner, Holly Bates, is our other PI coordinator. Their role is invaluable in this space, not just in educating our staff members as well, but also being able to suggest workflows. We have clinics that are literally only 2 providers all the way up to clinic multi-site practices that may have a total of 26 to 30 physicians and APPs in them. So being able to adjust according to each individual practice is definitely needed as well. And always celebrate the wins. We should celebrate any time we make progress. So now this is probably what most people want to hear, which is the challenges that we had during COVID. So just like everybody else across the nation, we moved to essential visits only during the safer at home quarantine. Our system chose to focus on wellness visits under 2 to make sure that we were keeping up with those primary series of vaccines. But then after about 6 weeks, Atrium Health really developed a comprehensive reentry plan. And the core of that was setting expectations for what we termed COVID safe care. Within that umbrella of COVID safe care, Children's made some workflow changes that we really hope to address parent concerns and promote safety for children and parents alike. And some of those things included virtual visits for both well and sick care. When we went into COVID and safer at home, we had launched our on-demand virtual visit service for pediatrics literally 10 days prior. And so within a week of kind of the shutdown, we had pivoted and expanded virtual visit capability across all of our clinics. And we continued that into even well visits initially, because that allowed us to cut down on the amount of time that a family would spend in our clinics. We moved to online form completion. We changed patient flow within our offices so that families weren't coming in contact with each other. And we implemented a virtual waiting room, so they didn't even enter our doors until we were ready for them to go directly to their room. And of course, did universal masking and screening of everyone as they entered. And then we doubled down on things that we knew worked well. And so Atrium has an ongoing WellVisit Recall campaign. It runs all year long. We did pause it during Safer at Home, but basically, once we went into reentry, we launched that again. And any patient where it's been more than 14 months since their last wellness visit gets a call and a reminder to prompt them to schedule. Beyond that, we know that our patients like to hear from us directly. They feel their relationship is with the clinic. And so we developed an additional process where clinics could actually run a report looking at their lapsed well visits and reach out to those patients on top of the kind of centralized campaign that we run. So I wanted to share some takeaways specifically around the partnership that we've had with the American Cancer Society this past year. It really created a unified approach for all of our clinics to increase HPV vaccination rates. And our collective message to parents and patients is really now the same. So wherever they would turn within our system, they were hearing the same thing if they were seeing a pediatrician or one of our participating family medicine practices. And, you know, there's always a way to do it better, right? Just because we had had success in the past didn't mean that we were going to continue to have the same success or to do it the same way. Excuse me. And in fact, we were able to expand our repertoire in how we discuss HPV vaccine and all of the associated pros, cons, risks, benefits, et cetera, with families. And, you know, really gave us standard evidence-based, well-validated tools that we can use every day with our families. In addition, there were some questions everybody was invited to submit prior to today's webinar. And I pulled out a few that I don't think I was able to really address during the talk. And so I know there were some questions around studies with males and specific tools for providers to use. That the HPV Roundtable can definitely, they have been a great resource for us during this as well. Tips for getting patients in for a second HPV vaccine. One of the things is we have the ability to run reports so we can see who is due. And I would say this works for the first dose in the series as well as the second, but being able to work those reports regularly is important. The other thing is our nursing visit schedules run kind of for eternity. And so when they see us for their well visit and get their first one, it's important to be able to schedule their second one right then and there. And that will generate a reminder for the parent when it comes time for their 6-month second dose. There was a question about vaccine rates in rural areas or more conservative areas. I would say all throughout our service area is pretty conservative. We do cover urban, suburban, rural areas with all of our practices, and we kind of hear similar concerns at all levels. And so the strategy around really focusing on preventing cancer and trying to personalize that for families has been one of the ways that we've found to be successful in addressing those concerns. When we can take it away from being about, you know, a focus on it being sexually transmitted, and we can really focus on cancer and the impact we can have in preventing it by vaccinating at these younger ages, that resonates with parents. Finally, it was just, I wanted to double down again on the role of social media and trying to use that to your advantage. I won't say that that's been the primary tool that's been successful, but it is important to be able to get the positive message out there as much as possible. And with that, that brings me to the end of our presentation, and I just want to say thank you again.
Thank you, Dr. News. It's a true honor to have Atrium Health on this call. When I saw your run chart, I got so excited about it. And my ACS colleagues were just so enamored with the work your team is doing. And it's great to hear some good news in these times. We have about 4 great questions in the Q&A, but because we're getting short on time, I'm going to ask that maybe between you and Stephanie, Dr. News, that you could reply to those questions in the pod, and we can also make sure we send those out after so that we can keep going with the slides so that we have enough time for Dr. Staslow. Does that work?
Absolutely. I'll start typing now.
Great. Thank you so much.
Thank you.
Okay, Nikki, we're now moving on to our next featured presenter today. Let's see, I'm controlling the screen. Are we moving? There we go, there she is. It's my honor to present the principal investigator of the National HPV Vaccination Roundtable and the managing director of HPV and OBGYN cancers at the American Cancer Society, the one and only Dr. Debbie Staslow. Debbie, take it away.
Thanks, Jen. So, getting a study in my inbox 2 weeks ago with the title that you see on the screen is pretty much a really great way to start the day. So as many of you know, for the last 14 years, since 2006 or maybe even more, we've been able to say with absolute certainty that HPV vaccination prevents advanced precancers, and that we know with absolute certainty that when you prevent advanced precancers, you prevent cancer for the HPV cancers. But you always get those few naysayers who say, yeah, but I need to see cancer prevention. How many cancers have been prevented by HPV vaccine? And so this paper that came out from Sweden, 1.7 million females, showing prevention, protection against cervical cancer, gives us an absolute certain answer to those naysayers and the entire community. So in Sweden, they had, again, the whole sample size was 1.7 million. They looked from ages 10 to 30. They were only vaccinating females, and with the quadrivalent vaccine at the time. I don't know if they're using the 9-valent now or not. So over 500,000 of these children and young women were vaccinated, and almost all of the vaccination was in ages 10 to 16. So they offered it for ages 13 to 17, and then several years later, they added it to the school-based vaccination for 10 to 12-year-olds and did catch up through the age of 18. And you still got, some people who were getting vaccinated even after the age of 18, not that many. And then screening in Sweden, everybody is invited to participate in an organized screening program, which is Pap tests every 3 years from age 23 to 29, and now a primary HPV every 3 years for ages 30 to 64. And after age 50, it goes to 5 to 7 years, depending on which part of the country. And the main outcome that this study was measuring was cervical cancer by age 31. So it's not that common to get cervical cancer in your 20s, but given the timing of getting the vaccine and the timing of the study, we can only look right now at cervical cancer in younger women, but each year we'll be able to look a little bit further out. So large sample size, really important outcome, and here are the results. So there were 2 cases of cancer among the 439,000 females aged 10 to 16 when they were vaccinated. 10 cases for those vaccinated. There were about 60,000 who were vaccinated as late teens, and 17 cases among the 30,000 or so that were vaccinated in their 20s. And there were 528,000 unvaccinated females included in the study. Most of the ones who were excluded were because they reached the age of 31, and so they weren't counted in the study. And from those who were counted in the study, there were 538 cases of cancer. And so that translates, once you adjust for different factors, to 88% protection. 88% protection for those who were vaccinated before the age of 17. And this was with the quadrivalent vaccine, which only protects against type 16 and 18, which caused 70% of cervical cancer. So how did that happen? Well, there's 2 explanations. One is that there is some cross protection. These vaccines do protect against some additional types of HPV, but the main reason in this study is that while types 16 and 18 cause 70% of all cervical cancers, they cause a greater percent of the cancers that occur in the youngest women. These are the most aggressive cancers caused by the most aggressive of the HPV types. So this is great news. The vaccine is performing even better than we had anticipated. Now, age of vaccination obviously matters. In this study, which is shown in the bottom right corner, you can see that protection drops from 88% to 64% if you include those vaccinated through age 19. And if you look at those vaccinated from age 17 to 30, the protection was only 53%. And again, most of these were very close to age 17. There were not that many that were vaccinated later. And what I did is I included another study, set of outcomes from a study from Scotland in the top left corner of this slide, showing some similar data looking at effectiveness against advanced cervical precancer, and showing you it's a little, the age stratification is a little bit more specific. When vaccination happened at age 12 to 13, you saw a similar protection of 86%. age of vaccination at 17 gave 50%, 51% protection, and vaccination at 18 to 21 gave 15% vaccination. So one of the questions that was sent in from one of the participants was, oh, so now that you've seen this study, now that you see the 50% protection when vaccination happened in the 17 to 30-year-olds, is ACS going to reconsider not recommending adult vaccination? And the answer is absolutely not. By age 21, the protection is down to 15%. It's going even lower when vaccination happens by 26, which is the catch-up recommendation age in the United States by ACIP, by CDC, by the American Cancer Society. So the effectiveness goes down to a minimal amount. 0.3% of cervical cancers will be prevented if we do adult vaccination, compared to so 99% of the prevention will happen before the age of 26. So here are some of the other questions. A couple of questions about sexual activity. While Sweden does a great job of tracking who got vaccinated, how many doses at what age, they don't ask whether the girls were sexually active at the time of vaccination. So we can't answer this. What I can say is that the average age of onset of sexual activity in Sweden is 15. In the United States, it's 17. So it's pretty similar. And that sexual activity does increase with age. And so that is a big reason why effectiveness of the vaccine decreases with age. What the study shows about vaccinating the older girls is that the vaccine is less effective, probably because of exposure to HPV. How will the data impact screening as this cohort turns 21? Actually, in Sweden, it's as they turn 23. And it won't. So this vaccine was quadrivalent. It protects against 70%, in this case 88%, but as the cohort gets older, you'll see a little bit more of the cervical cancers that are not protected by the quadrivalent vaccine. So if or when Sweden switches to Gardasil 9, the 9-valent vaccine, maybe that will have more of an impact, or maybe they will, like the United States, up their age to 25 or later. Most countries do start somewhere between 25 and 30. Are similar studies underway in the US? In general, no, because we do not have registries. Instead, we have population-wide studies that have shown that the rate of cervical cancers among young women has gone down in the US, but we are not able to say it's gone down this much in vaccinated females and this much in unvaccinated, with the exception of the state of New Mexico, which does have a statewide registry of all vaccinations and all screening and follow-up, and they have shown that the advanced precancers have gone down to pretty much zero in the state where the females have been vaccinated. So with new data, I already answered, we will not be reassessing adult vaccination. It is just almost not effective. It is safe, but it is, the effectiveness is close to zero. How do we message this data? I think the message is pretty much the same. As you heard from the earlier speakers, we push cancer prevention. We were confident that we could say that the vaccine prevented cancers based on the knowledge we had, which was mostly advanced precancer. Now we can be even more certain. But the bottom line message is the same. This vaccine prevents cancer. This vaccine prevents 6 types of cancer. As far as male HPV vaccines, very few countries vaccinate males, and so there's not much data. And are there current studies? Well, probably population studies, but one problem is that, so of the male cancers, there are 3. One is anal, and we do have precancers for anal cancer, but most men are not screened for anal cancer. It's not recommended. Plus, anal cancer is not that common, particularly in men. Penile cancer is even rarer, and so those numbers are extremely hard to go by. And throat cancer is even more common in men than cervical cancer in women. However, the average age of getting oropharyngeal cancer is much later than for cervical cancer, and so it will be a long time before we see oropharyngeal cancer rates go down. We may have more data coming on oral HPV infection, so that will be telling. Next question, next slide.
Debbie, one more question that came in that will go along with this first part of content. Amongst the women in the study who got cervical cancer, do you know what the HPV type was, and was that looked into?
They did not report that they did genotyping. In New Mexico, they are genotyping everything, and so that group is just churning out papers. We do know that most of the positives are of the types that are not in the vaccine, especially when most of the vaccination is happening on time. So I wanted to speak briefly about screening, because we did get a bunch of questions about this. So in July, in addition to updating the ACS recommendations on vaccination with a big push for vaccinating at ages 9 to 12, as opposed to 11 to 12 or starting at 9, we also updated our screening recommendations. And the big one is that screening for all women and for all individuals with the cervix should start at age 25, and the strongly preferred approach is to screen every 5 years with the HPV test, just the HPV test, through age 65, and then to stop screening. And we do have some caveats. We are in a period of transition. So for many people around the country, primary HPV testing, which is another way of saying HPV on its own without the Pap test, is not available yet. And therefore, it is still acceptable to continue screening with the Pap every 3 years, or co-testing with both the Pap and HPV every 5 years. Next slide. We do have 2 other recommendations about when screening can stop, and that screening should only be for people with a cervix. But most of the questions were on that first recommendation, and I'll show you some on the next slide. So there's, oh, I'm sorry. Before I go there, I want to emphasize again that this is a transitional recommendation. The science is absolutely there. We know that our recommendation is science-based. However, we also know that access is not yet available for everybody for primary testing. And that is why we are announcing and giving a heads up to all the laboratories and all the health systems and all the providers and the public that the next time we issue a guideline, whether it's in 2 years or 3 years or 4 years, the Pap test and the co-test will not be part of our guideline. And then the other planning for the future issue, which we have been planning for decades now, but I think the time is finally here. On the next slide is that self-sampling is, the evidence has been here for a while. We need to get through the logistics, and we need to get FDA approval. And if there's one silver lining of COVID, it's that the FDA is likely to fast track approval of self-sampling. This is only for HPV testing, not for Pap or co-testing. Self-sampling for HPV test using a collection sample that looks a little bit like a small tampon. It can be done at home. It can be done in the doctor's office the way a urine test is given. Very high acceptance among women, and very strong science, but again, lots of logistics to work out. Will it be mailed in? How will the follow-up be done, etc. So on the next and I believe final slide are a couple of questions that you sent in. There seems to be a lot of concern that guidelines differ between different groups. And that is a big concern because it's confusing if different groups give different guidelines. In 2012, all 3 groups updated their guideline in the same year, and they were almost identical. 2 years ago, the U.S. Preventive Services Task Force updated their guideline, and at the time in their draft, they said, let's go to primary HPV testing, and they didn't include co-testing. We only had 1 test approved for primary testing by the FDA at that point, and the access issues were problematic. And so the final guideline included co-testing, but preferred primary testing to co-testing. And ACOG has not updated their guideline yet, but does include primary testing. So these differences now are just a matter of timing. ACOG and the task force, I predict, will match the ACS guideline in their next round, and hopefully that will be soon. Probably ACOG will be a little sooner than the task force. The task force traditionally has not looked at the question of when to start screening. They have followed our lead, so we look at their data and add to it on how to screen, with what test and how often, and they tend to look at our data on when to start and when to stop and under what circumstances. It is a bit controversial moving to age 25, but our guideline, which is very long, really spells out the reasons. And the vaccination is almost an afterthought. We know a lot of women in this country or girls have not been vaccinated. And so really the age to start is based on the very, very, very small number of cancers before age 25. I can tell you that in 2017, that number was 71. So you're screening tens of millions of young women to find 71 cancers that you probably won't find because screening just hasn't been finding these cancers and preventing these cancers before age 25. The other somewhat controversial change was this transition to primary testing, and mostly it's a concern about access, but the answer is not to have a non-evidence-based screening guideline. The answer is to help transition and increase access, and that is a huge focus of ACS working with many partners. And so I will stop there.
Thanks, Debbie. There's one more comment in the Q&A box, if you could maybe look at that, from Pam. And I'm going to keep going given that we only have 1 minute left. So want to turn myself back on here. Last time we were together, planned out several of these webinars throughout the year. So the next time that we plan on reaching out is specifically to those organizations that signed on to ask you in December to do a pulse survey and tell us about HPV vaccination work this year and what your plans are going forward. And then in January, we plan to host another public webinar, look back on the year of the pandemic, regroup, look what we're doing on getting on track, and maybe asking Admiral Giroir again to address and talk about where we're going forward as a nation. So please plan to hear more from us about that. Also wanted to remind you, something about evidence-based tools and interventions. Well, guess what? We're chock full around the website. So this is a resource. This is actually a document that you can download and use with your staff holders. It's a front and back links to all social media platforms, our website. There's a scannable QR code that you can use that takes you to the resource library. In the upper right corner, you see a screenshot of that, and you can go in there and you can sort by different audiences or search by keywords. We have more than 250 materials in there. We're adding, albeit slowly, to that. So please make sure you go to our different platforms to access those many tools and resources. So with that, we'd like to conclude and thank you so much for making time to attend this webinar today. The members of the roundtable, thank you. And as always, we thank the CDC for their support of the National HPV Vaccination Roundtable. Have a wonderful week, everyone.